Our next panelist, Dr. Rangsima Airawanwat, who is the Chief of Party USAID Community Partnership Project for capacity building of community health workers on KPLHS, managed by Thai Red Cross. She has over 30 years of experience in capacity building, training, and teaching in non-government organizations and universities at local and international level. Her specialization comprises of program management, monitoring and evaluation, programming for key populations, organizational and strategic management, public administration, policy evaluation, and behavioral research. She has her PhD from the University of North Texas in public administration. And Dr. Airawanwat is going to talk to us about sustainability of KPLHS through capacity building platform, which I think would answer many the questions from many of you here.
So I'm very pleased to walk you through the capacity building for sustainability this morning. So by this time, I think that everyone knows who the oldest among the presenters today. Okay, just a quick review of key population-led health service. What do we mean by this? For us, we mean that the health services provided by trained and certified community health workers to meet the need and lifestyle of key population. This will include MSM, TG women, MSW, TG sex worker, as well as PWIT. So why? Everyone knows already that the accessibility to HIV care and services in many countries is very limited. Why? It's because some of them work after hours, and then the cost of the service is quite high, so on and so forth. So we would like to provide accessibility. Availability, yes, there's availability service in the government facilities, but would that be appropriate to match with their need? That's another option. And acceptability, whether the service provider are friendly or not. But the last one is the quality. So in order to solve all of this, we would like to have the key population who is the service provider to ensure that there's the accessibility for the service, availability, acceptability. The last one is more important, whether the quality provided by key population is acceptable to the standard of the country or not. So let's talk a little bit about the background. I think this background is the same as any country. For HIV, capacity building at the very beginning has been offered by international NGOs or other international organizations. They have trained many of the local people, and then it has been translated as the capacity of the local people. So the area that has been built, of course, reach, recruit, testing, treatment, and retention. But you may know that this capacity building is integrated as the part of programs, or if they're the program funded by international organization, this capacity building will be there. But if it's finished, then it's gone. There are some of the organizations in Thailand that start working or doing capacity building on this area, such as for Thai Red Cross. We have been offering HIV training for key population, especially on HIV counseling, since 1998. So we have a long experience on providing this capacity building. But in Thailand, prior to our program, we found that there is no systematic training program that include both knowledge, practice, as well as certification. As one of the audience has been asked, oh, what is the certification for them? How would you be sure that the quality provided by community health worker will be quality? So last year, we received the money from USAID to do the project called USAID Community Partnership Project. This project is intended to build or establish a sustainable TA platform, or you can call a national training center, to build the capacity of CBO to provide quality key population-led health service for key population. So we have 4 partners in here. Thai Red Cross AIDS Research Center, Rainbow Sky Association of Thailand, and then service worker in group or swing that Kunti is representing today. And we have M+ Foundation as the partners. So for key population-led health service, for reach, recruit, test, treat, prevent, and retain. For reach and recruit, there is no problem at all because right now government is very happy that the CBO is helping to do reach and recruit of people to go for testing. But for tests, we would like to make sure that the test is provided by lay provider so that it can be done off hours and user-friendly, so on and so forth. But if the test is negative, then we would like to ensure that there is continuing prevention for them by the lay provider can provide PrEP and PEP as well as condom and lubricant for the clients. And also ensure that they will come back and do testing during a certain period of time. But if the test is positive, then we will refer for them for treatment. But in a stable case, we would like to make sure that we can be able to provide ART dispensing according to the differentiated service delivery model as well as other prevention method, and ensure that there is the treatment adherence. So all of this would be the background. Why I have to say about this? Because when you design the training module, you need to know what are the core competencies that the trainee has to do. So we developed the training module according to the core competency that the community health workers has to do. But to make sure that they are on the same page, we have gender sensitivity because they have to work with key population, and this is the key to make the service that we provide to be friendly, as well as they have to have basic HIV and related disease to the standard that they are available to do the job. After that, then the module will go to the training and certification committee for review and approve, and then we can conduct the training. Once the training is finished, then they will go to practice, and there is the QA/QI group from linkages program provide on-the-job training. And then after that, then we will assess them to make sure that the practice is all right. Then the community health worker will be certified, and then we'll be able to leverage resources and sustain the TA platform. That's the module that we are thinking. So as I already mentioned, so the curriculum has been developed based on core competency. And then the prerequisite is that the gender sensitivity as well as HIV basics. For training methodology, we don't do training by ourselves. What we would like to do is that long-term sustainability of key population. So we do training of trainers, use key population from our community health worker as the trainers. After that, then they will do face-to-face training for people who come from the training. And then if they already attend the training long time ago, not our training, we do refresher, as well as we will do online courses as well. So we already said that, okay, to ensure that they know, they have the knowledge, then there will be the test. They have to pass the score of 80% score or higher on knowledge test. After that, they will be sent for practicum in our CBO partners for 3 months. After 3 months, then there will be the assessment to ensure that they can apply the knowledge in their work. Then we will provide the certification. So if we compare our system with others, you can see that, okay, for Ethiopia, this is like the country that integrate health education for community health worker, which they call as health education worker, in their national curriculum. So you can see that for this one, it includes both like primary health care, disease prevention, including HIV, TB, and malaria. For the red one, it contains only the course for HIV. You can see that they have the same thing, counseling, rapid HIV testing, and follow-up, and first-line ART. For Texas, why this is important? Because this is the first state in the US to provide training certification from community health worker. So they have the knowledge base specific for chronic disease, but didn't have on HIV. For New York State, they have 3 tags for community health worker, the one for positive HIV, the one for positive HCV, and then for PVID. But you can see the curriculum in red. The courses is the same. HIV testing, HIV counseling, so on and so forth. So the last one is our curriculum. So it's pretty much the same thing. We also have like the cross-cutting one, which is communication and data management. For criteria, for Ethiopia, it is a 1-year training. For Texas, 160 hours, but no assessment. For New York State, yes, 75%, which is lower than us, but 500 hours of practicum and signed code of ethics. For us, pretty much the same as New York State, but the criteria is 80%, which is higher. And also, who's going to certify them? For Ethiopia, it's MOH. For Texas, it's State Committee of Department of State Health Services. And New York State, there is no formal review, just only the State University of New York, Stony Brook, that provides certification. For us, we be provided by training committee. For the training committee, they also do review of the training system, appoint the person to review the training curriculum, as well as appoint the person who do the assessment. What have we done so far? We have developed 2 training curriculum, trained 22 facilitators, and we select as 12 star facilitators. During the course that they did the training, we get 3.5 to 3.9 rating scale for them on the 4-point rating scale. We already did 2 basic HIV training, and then 108 community health worker trained, and 31 qualify for assessment. The assessment will come later. So, want to be a pro, follow me. You might ask, what is this? It's part of our marketing plan. At that early this year, we have the workshop on marketing and business plan. So we thought that, there are a lot of training all over the world, and why people have to come and then train by us, right? So we think that, okay, we have to have value proposition that we have to hand to trainees. What we would like to do is that the training has to be fun to match with the lifestyle of new generation. It has to be easy, but intensive enough, modern, as well as practical. So these are the value proposition that people will get from us. And we also use the social media, which is Facebook fan page called Pro Partnership Training Program to help. So we will arrange the TA platform launch on August 28, and if anyone is interested, you are welcome to join in Bangkok. We also will arrange the regional seminar on task shifting as the advocacy to advocate for task shifting to have a better role for community health workers in service delivery. This will be in August 28 and 29. If there are anyone who would like to be a sponsor in the future to provide sponsorship for the trainee who are in need, please feel free to contact me. And the last one, from our advocacy, we already submit our training and certification system to the Ministry of Public Health through Department of Communication Disease Control. So right now, they have the effort to develop minimum standard for KPLHS service delivery. For on the certification system and then on the standard of TTPR and facility, we will provide the TA for them. They also have a plan to develop the service delivery standard and standard for RI as well, which will be involved. And then they are thinking about that there should be a national subcommittee on certification to be established. So we are in the process of trying to push it forward right now. And for domestic funding, as far as you know, National Health Security Office in Thailand is now piloting direct funding to CBO for RR and also indirect funding to CBO for treatment through hospital. What is our role? We will send the name of trainees and organization to NHSO so that they know who are the quality people sitting in the organization, so that we help point out for long-term sustainability so that they can receive funding. We hope also that after the 3-year project, we will expand and do some other training courses, tailor-made course to match the need, and then resource mobilization for our sustainability. So that will be from all. The last one is the acknowledgement from our partner, and thank you very much for listening. Thank you.